So the next speaker is Dr. Neha Rai, and she will be talking on the constricted pupil. Now, Neha, it's interesting to note, I was just going through a CV, MBBS gold medalist, MD gold medalist, DM gold medalist. I do not know of anyone. I don't think Padma has all three gold medals. I'm going to tease her, right? Great, Neha. That's good to see all this. You have a hat trick of gold medals, and she's got multiple awards after that. So, and she was a Torrent Young Scholar. Okay, I consider that a very prestigious quiz contest. I remember Rupa getting that award. I remember Anu getting that award. Parveen Keshav also got that award. So I consider this to be a really, terrific feather in your cap, besides, of course, the multiple accolades that you have won. So she will be talking on the constricted pupil. Over to you, Neha.
Thank you, sir. A very good afternoon. At the outset, I'd like to thank the team of ION who gave me an opportunity to speak on such an important masterclass. When I received the topic, I thought that it is an easy go. But when I sat and searched into the literature, I found that it was there was not even a single paper or article mentioning with the name of constricted pupil or the small pupil or the mitotic pupil. So in the next 30 minutes, I hope that I'll be able to do justice to the topic which is given to me. I consider pupil as actually not just as a window, but as a filter through which we see the whole world. It is actually a filter because it regulates its size depending upon the perception of the light that it requires. It is used to increase the focus onto the retina. And one way to decode the eyes is to observe the non-verbal eyes clues, and they speak through the pupil size. The pupil size altered not only by the external stimulus, but also by the internal stimulus, especially emotions. Before we go into the details of the pupil, we must know, or we can revise the basic anatomy and physiology of the pupil. The pupil, the iris actually is made up of two different types of muscles. One is the constrictor pupillae and the second is the dilator pupillae. So the radial muscles that are seen around the iris, which are called as the dilator pupillae, when they contract leads to the dilation of the pupil. And so these are under the control of the sympathetic nervous system, which is regulated from the hypothalamus. Whereas the center of the muscles, which we can see, that is the circular muscles, which when contract lead to the decrease in the aperture of the pupil, and these muscles are the sphincter pupillae, and the sphincter pupillae is being regulated by the parasympathetic nervous system from the midbrain, the Edinger-Westphal nucleus. Before we enter, we should know what important things are there in the examination of the pupil. We should examine the light reflex. We should know about the real near reflex, the psychosensory response, the dilation test, and the swinging flashlight test. Pupillary light reflex. Whenever the light is focused on one of the eye, the pupil that constrict or the constriction of the stimulated pupil leads to the direct light reflex, whereas stimulation of the contralateral pupil leads to the consensual light reflex. After a latency of about 200 to 450 milliseconds, the pupil starts constricting, but after having reached to its maximum size, the pupil redilates. It's virtually impossible to define a normal pupillary reflex because the response depends on multiple intrinsic and extrinsic factors. It is dependent on the stimulus. The higher or the stronger the stimulus, the faster and the brisker and the prolonged will be the response. It varies between individual and individual, depending upon the mental state of the patient. Anxious people will have more dilated, less reactive pupils. So on an average, we must take at least 4 to 6 pupillary responses to comment upon the pupillary light reflex. The pathway is very simplified in the given figure. Most of the parasympathetic fibers for the pupil usually serve accommodation, and there only 3% of the fibers are there which serve the pupillary sphincter. The parasympathetic fibers are located superiorly and superficially in the oculomotor nerve, and so they are vulnerable to compression. Then the afferent pathway consisting starting from the retina, the optic nerve, the chiasma, the orbital, the optic tract, and ultimately reach the pretectal nucleus. So at the pretectal nucleus, the crossed fibers overweigh the uncrossed fibers. And this explains why anisocoria cannot be caused by the damage of an afferent pathway, pupillary pathway. Even if a single optic nerve is severely damaged, the light reflex will be preserved. So even unilateral blindness do not cause or lead to anisocoria. Anisocoria always and always indicate an efferent problem. Then from these, the pathway relates to the Edinger-Westphal nucleus and then ultimately through the sphincter pupillae. Near response, the pupil constricts and improves the depth of constricts to improve the depth of the focus. This response is less consistent, and it is transient. Normally, there may be no pupillary response at all until the target come close to at least 10 centimeters. We have to take a distant target, dim the light of the room, and then the near target should be preferably patient's thumb. The important thing is both the distant and the near target should have the same luminance. It should not be a flashlight so as to avoid the light-induced pupillary movements. So this is the near reflex. It's actually a triad of the constriction of the pupil, convergence of the eyeball, and increase in the curvature of the lens. The important thing is from the visual cortex, then these fibers go through the frontal eye field. And the important thing is fibers from the occipital cortex reach the pupillary region, dorsal to the Edinger-Westphal nucleus. And these fibers directly bypass the pretectal regions. So the lesions in the dorsal midbrain may abolish the pupillary light reflex, but leave the near reflex unaffected, thus leading to the light-near dissociation. The another response is psychosensory response. This response is again transient. It's difficult to recognize. The pupils respond to pain, fear, stress, and to mental arithmetics as well as to mechanical efforts. The important thing for us is that dilated, poorly reactive pupil may simply be a cause of patient's excitement. So we should calm down the patient and recheck again. And then the dilation test. Dilation test is performed whenever there is anisocoria with the normal light reflex. So whenever we think for an Horner syndrome, dilation test is must. The normal pupil dilates within 5 seconds, but the abnormal pupil, so as in Horner's pupil, dilates very slowly. It may finally become almost as large as the normal pupil, but after 10 to 20 seconds. This is because of a sympathetic deficit. However, it is very difficult to observe for the dilation test because the room has to be dark and we can use infrared light for same. This test needs to be repeated at least 4 times at least, and the photographs are taken once the light is switched off and especially at 4 to 5 seconds, then at 20 seconds. So dilation test, Horner's pupil will lag behind in dilation, especially at 4 to 5 seconds. The clinical features that best differentiates Horner syndrome from the physiological anisocoria is the dilation test. And it is diagnostic for Horner syndrome, but the important thing is it is demonstrable only in 50% of the patients. Then the swinging flashlight test. This is especially the test used to detect the afferent pathway. The direct light reactions between both the eyes are compared and the difference between these visual afferent pathways are seen. Just few important salient finds, that is the room should be darkest enough and distant targets and direct light should be used. Do not constrict the pupil more than 3 to 4 millimeters and the light should be shined for 3 to 4 seconds. So when so we can see when the normal is stimulated, both the pupils react normally, but absence of direct light reflex on the affected eye and absence of consensual light reflex on the normal side is abnormal. So to sum up, there are 3 important steps in the pupillary examination. First is we need to check for the efferent pathway, most important, and then only we can go for the afferent pathway testing. The efferent pathway testing has to be done with the light response as well as anisocoria. And then the afferent pathway testing is done with the help of swinging flashlight test. So for whenever we check the pupil, check the size, shape, equality, position, reaction to bright light. These are best tested in semi-dilated pupils. It is best to test semi-dilated pupil in the dimly lighted room. Fixate the object, use a distant object so as to avoid convergence. and avoid touching the patient with even hands or instruments, as psychosensory response may lead to mydriasis or hyperactive pupil. Avoid using the term perla, that is pupils equal round, reactive to light and accommodation, as we usually do. It is convenient but incomplete description of the pupillary motor function, and it omits the actual shape, size of the pupil, the speed and the extent of constriction. We can grade the pupils from 1 to 1 plus to 4 plus. Anisocoria is said whenever the difference is roughly more than 0.4 millimeters, usually less observed. 8% of the young people and 15% of the elderly people can have anisocoria with transient sympathetic imbalance. And this also depends upon the illumination, because anisocoria is more prominent when the light of the room is reduced. It's better to check the older photographs of the patient. So whenever the patient has anisocoria, which pupil is abnormal? So this is when the pupil reacts equally in the dark. So the pupil dilates in the dark and constricts in the light. Again, the another pupil, when light is focused on the left eye, both the pupils constrict, the direct and the consensual light effects are present, as well as to the near target. So this is normal. On the second, whenever there is dark, the pupil ideally should dilate, but the pupil that constrict is abnormal, because whenever in the dark, the pupils dilate, sympathetic system, but on the light, the pupils constrict. So this is the anisocoria, which is more in the dark. The small pupil is abnormal. Whereas whenever, so this is dark, both the pupils are dilated, but when anisocoria is there more in the light. So in the light, the large pupil, actually during the light, the pupil should constrict with the help of the parasympathetic nervous system. So when the pupil is not constricting, then in the light, the larger pupil is abnormal. And then there may be slight anisocoria, but the pupils react equally in the light as well as in the dark and in the near target. So this is physiological anisocoria, which is equal in the light and the dark. So an approach to anisocoria: reveal the history of ocular trauma, check the old photographs, use any tropical medications, exposure to any toxins or drugs, and associated ocular or neurological symptoms. And then we need to check for the anisocoria, which is in the dark or in the light. Whenever the anisocoria is more in the dark, as we said, that it is probably a sympathetic deficit. We have to check for the dilation lag and the ptosis, and then use pharmacological testing to see whether it's a Horner or Horner syndrome or a physiological anisocoria. The pupil that responds equally in the dark and in the light is possibly the physiological anisocoria, whereas the pupil which is large is abnormal, and which is actually larger in the light is abnormal. Here, if there is associated ptosis and ophthalmoplegia, then possible third nerve palsy. However, if the pupil is sluggishly reacting to light and there is light near dissociation, we can use pilocarpine and think for Eddy's pupil or even pharmacological anisocoria. Coming to my topic given was constricted pupil. So I'll sum up the causes of constricted pupil in the following table. First, we'll see the sleep, senile, and congenital causes of anisocoria. Deeper the sleep, smaller are the pupils. It is difficult to observe the pupil even with pupillometry during the sleep, and some tests are done, experiments are done. This is a research topic. Pupils change their size with age. They are smaller in the newborn, increase size in the teenagers, and pupil reaches a size until 15 years of age. So teenagers have the largest pupil, as large as 5 to 9 mm in the dark. From its maximum, the pupil then again loses size on an average of 0.04 millimeters per year, approximately linearly. And so that in a 60-year-old, the pupil will be as small as 4 to 7 mm, and that may be normal. The pupillar light reflection reaction is independent of age. And then senile pupil. When I interacted with my ophthalmology colleagues, this is one of the cause of the constricted pupil that come to the ophthalmopedies. But when I searched into the literature, I could not find much articles on the senile pupil. This is one of the oldest article that I've ever quoted. So this article was actually published in 1943. This was a histopathological examination of 14 elder patients, and they found that there was atrophy and degenerative process in the sphincter and the dilator pupillae muscle. They concluded that senile meiosis and rigidity of the pupil is primarily the arteriosclerotic process of the iris vessels and subsequently degeneration of these muscles. And most important is that these pupils, the senile pupil is not just the constricted pupil, but moreover, it is a pupil which lacks the ability to dilate proper because of the rigidity. Congenital meiosis, it's a meiosis which is usually present bilateral because of congenital absence of the iris dilator muscle, could be sporadic or inherited. We should not forget acute anterior uveitis as a cause of the meiotic pupils. The meiosis of the eye in iritis results from the release of the substance P in the iris sphincter muscles. And the dilation with the mediatrix is even difficult because of the adhesions between the iris and the lens and because of the formation of posterior synechies. So these adhesions in chronic iritis thus leads to the distortion of the shape of the pupil, and these pupils are usually fixed pupils. Pupil is also affected immediately after the trauma, which is called as spastic meiosis. Profound but usually transient effect is seen, and usually it is often followed by iridoplasia. Then those causes which lead to light near dissociation and lead to constricted pupil. The two important causes of light near dissociation is one, the Aride-Robertson pupil, and the second is the tonic pupil, which are again divided in three important causes, the ADs, the neuropathic, and the pupils secondary to the local trauma. However, it will be covered in detail in the coming talk. But the important thing is these tonic pupils are actually large pupil, dilated pupils. The baseline size of the pupil decreases over time because of the tonic firing in the aberrant accommodative fibers innervating the sphincters. After several months or years, it is common for a chronic total tonic pupil to be the larger pupil in the room light and relatively smaller pupil in the dim light because it fails to fully constrict or fully dilate. Hence, it is called as a little old Addis pupil. Accommodate the ARP, that is Aride-Robertson pupil. This we have often seen that accommodation reflex present and the pupillary reflex absent. So the pupil constricts poorly to the light, but on accommodation, the pupil constricts briskly. Aride-Robertson pupil in 1869, Aride-Robertson described his famous pupillary signs in two papers, said that I could not observe any contraction in either pupil under the influence of light, but on accommodating the eyes for a near object, both the pupils constricted. So these are bilateral, small, irregular pupils with light near dissociation. They develop gradually over months to years, poor dilation with atropine and other mediatrics. They are highly specific for late syphilis, but it's still a question. The pathophysiology, probably rostral midbrain is affected, and so rostral midbrain is affected, and thus leading to sparing of the pretectal nucleus, and just the accommodation reflex is present in these pupils. So typically Aride-Robertson pupil with positive serology for the syphilis is rare at present in the post-antibiotic era. Aride-Robertson pupil could eventually be a long-standing tonic pupil because tonic pupil tends to become narrow over some years. So consider Aride-Robertson pupil not only as its own entity, but also as an entity for long-standing tonic pupils. The other is coming to the next cause of the constricted pupil, that is the most important, the oculosympathetic dysfunction caused by the Horner syndrome. So Horner syndrome is interruption of the oculosympathetic pathway. The typical triad of ptosis, meiosis, and anhidrosis was given forward by the Horner in 1869. The oculosympathetic pathway supplies the sympathetic innervation to the sweat glands, to the dilator muscles of the eyes, and the retractor muscles of the upper and the lower eyelid. This is the pathway, which is the preganglionic pathway and the postganglionic pathway. The preganglionic pathway is the lesions which is proximal to the superior cervical ganglion, and distal to this is the postganglionic pathway. Will come into detail. So the Horners, so the sympathetics, they do supply the molar muscles, which are the retractor of the upper and the lower eyelid. However, these are weak muscles just attached to the levator palpebrae superioris, and this is because of the molar muscles are involved. They are not a very strong lid elevators. So the pupil in the Horner syndrome is just, so the ptosis in the Horner syndrome is just mild, 1 to 2 mm, which can even be missed. The other finding is meiosis, and then we can see when the molar muscles, the lower lid molar muscles are laxed, then they can slightly, they can slightly lift up, leading to a picture of falsely small eye, and hence it is called as the pseudo anophthalmosis. Then the sweat secretion of one half of the face is decreased. At times when there can be flushing of the opposite half of the face, leading to the typical Herculean sign. And those children who have congenital Horner syndrome, then because of the sympathetic involvement, the pigmentation of the iris changes and leads to aniridia and abnormal pigmentation color of the another iris. Pattern of anhidrosis do differentiate between the first order, the second order, and the third order Horner syndrome. The first order Horner syndrome, the sweat secretion of the ipsilateral half of the face body is affected, whereas in the second order Horner syndrome, as the external carotid artery and the sympathetic plexus around the external carotid artery supplies the ipsilateral half of the face. So this is affected in the second order Horner syndrome. And if the third order Horner syndrome is there, which is distal to the superior cervical ganglion, then only a small patch of anhidrosis will be there just above the eyebrow, and it is usually missed. Coming to the three different parts of the Horner syndrome, that is first order Horner syndrome. So the sympathetics for the Horner syndrome, the first order neurons start from the hypothalamus, travels to the brainstem, and they reach to the spinal cord, the intermediolateral column of the spinal cord. And so here the most common affection is because of the stroke, brainstem stroke, that is Wallenberg syndrome, and the other pathologies can be pituitary tumor or the Arnold-Chiari malformations. So these figures showing the inflammation of the hypothalamus. We can see hematoma of the pontine hematoma, the most common cause as the lateral medullary syndrome, vertebral artery dissection, it's not very clearly visible, and the plaques of multiple sclerosis, and then the CV junction anomaly with descent of the tonsil and Arnold-Chiari malformation. Second order Horner syndrome begins from the spinal cord, that is C8 to T2 segments, and from here they accompany in the form of the sympathetic paraspinal plexus. Then below the carotid artery and through the inferior cervical ganglion, they reach the apex of the lung and then reach the superior cervical ganglion at the level of carotid dissection. The important pathology that affects this Horner syndrome is cervical rib, the tumors, and the most common is the Pancoast tumor. Any enlargement of the thyroid gland, thyroid nodules, or cervical lymph nodes enlargement secondary to carcinomas or Pancoast tumor, or even cervical ribs can lead to the second order Horner syndrome. These are the causes of second order Horner syndrome. Then the third order Horner syndrome, that is called as postganglionic, that is after the superior cervical ganglion. So here the sympathetic nerve form a plexus around the carotid artery, internal carotid artery. They enter into the cavernous sinus. In the cavernous sinus, they form a nerve which accompanies the sixth cranial nerve and then leaves and enters into the orbit through the V1 division of the fifth cranial nerve and then supplies the dilator pupillae through the long ciliary nerves. The most important affection here is the carotid arteries, is the carotid dissection and the tumors of the base of the skull and the jugular venous involvement. So carotid dissection and the nasopharyngiomas and craniopharyngiomas. Then the Horner syndrome is commonly associated with ICA dissection. It's very important. The carotid plexus is compressed by the hematoma, which is associated with the carotid dissection. So if a Horner syndrome is associated with ipsilateral orbital face or neck pain of acute onset, this should be considered as the ICA dissection unless proved otherwise. It has also been reported with the IGV, the internal jugular vein catheterization, a study from 76 patients, and they found that the onset of Horner syndrome ranges from few hours to even 19 days after the procedure. So we must remember this. And if we see what is the most common causes of Horner syndrome, the preganglionic are the most common cause. The preganglionic Horner syndrome is the most common. Then this was a case study of 318 patients of Horner syndrome, and they found that in both in the cohorts of the patients, they found that procedures in the neck, chest, skull base, and the paraspinal regions, followed by this was the most common cause, followed by cervical carotid artery dissection and tumor. So how to diagnose Horner syndrome, whether we should go for pharmacology or radiology. Pharmacological agents, that is cocaine, is not available nowadays. Apraclonidine is used for the testing of pharmacology for the Horner syndrome, but again, the availability is questionable. Hydroxyamphetamine was used theoretically to differentiate between the third order Horner syndrome, but actually, again, it's not available. So challenges are there because poor availability of the reagents are there. There are false positive results, and we need to wait. The time taken for these pharmacological testing is at least 1 week, because we have to wait between the cocaine or the cocaine testing and the hydroxyamphetamine testing for at least 2 to 3 days in between. Interval has to be taken. So, and even clinically also it's difficult because rarely it presents as a classical triad. Ptosis is very mild. Anisocoria, it's usually present in the dim light, and in the dim light also it is mostly pronounced 5 seconds after the darkness. So it's very difficult to even objectively define the dilation lag. Anhydrosis is again less reported because it's usually missed in the temperature control settings. So this was a very important and very nice algorithm where they gave, and it was published in 2013. They found that whenever we suspect a first order Horner syndrome, a brain MRI with or without the cervical screening should be done. But when we suspect the second or third order Horner syndrome, it should the imaging should be accompanied as a Horner's syndrome CT angio protocol. This CT angio protocol should include the circle of Wills, the orbits, and down to the level of aortic arch to the T4 and T5, with additional images of the lung apex and the orbits. And if it's not available, then CEMR can be done. Those patients who have Horner syndrome for as long as 1 year need not to be investigated, or else we need to reevaluate these patients after 6 weeks. Then pupils is affected in diabetes. This was a study which was done on 359 patients of unselected diabetic patients were taken, and they found that 21% of these patients have abnormal small pupil. Sympathetic iris innervation is mostly susceptible to the damage as compared to the parasympathetic nervous system, probably because of the greater length of the nerve pathway. Hypoxic damage and neovascularization of the iris, that is rubeosis, may cause stiffened iris and thus immobilize the iris. The enhanced response to the diabetic pupil to cholinomimetic drugs such as pilocarpine suggests that this is a denervation supersensitivity. So these are small, poorly dilated, poorly reactive pupils to light. They don't have much light near dissociation. They dilate poorly in dark even, and these are often called as sticky pupils. The anticholinergic drugs like topiramate produces less mydriasis in such diabetic pupils, and this is also used as a marker for diabetic neuropathies. The pupillary abnormalities have been noted to precede the cardiovascular symptoms, and acute hyperglycemia can also cause meiosis, which reverses when the normoglycemia is achieved. Horner syndrome is also seen in patients with cluster headache. In a study, they mentioned that 57 to 74% of the patients with cluster headache and 2 to 28% of the patients of hemicrania continua had features suggestive of Horner syndrome. The sympathetic dysfunction may be secondary to the neuropraxis effects of the carotid edema on the sympathetic plexus, or may signify just a generalized sympathetic dysfunction. And many a times cluster headache may be because with autonomic features, or there may be autonomic features alone without any headaches. The another cause of dilated pupil in neurodegenerative disease, mostly mentioned in the progressive supranuclear palsy. In a study, they mentioned that 71% of the patients of PSP presented with pathologically small pupil in darkness. Coming to last few, that is drug effect, drug overdose, and coma. Pupillary sphincter displays the muscarinic and cholinergic receptors, whereas the dilator has the adrenergic receptors. The ciliary muscles, this is very important. The ciliary muscles have both cholinergic and adrenergic receptors, but for accommodation, the cholinergic receptors are only important. So the adrenergic or the anti-adrenergic acting drugs will not influence accommodation in a clinically relevant manner, whereas a parasympatholytic drugs will lead to cycloplegia. So a dilator muscle, and the second thing is the dilator muscle is considerably weaker than the sphincter muscles. So when the pupil is dilated by an adrenergic drug, say phenylephrine, accommodation is not impaired. The dilated pupil still constricts with a strong light. That is why the anticholinergic drugs are often preferred for ophthalmoscopy, despite their unpleasant action of accommodation. These are the tropical mitotics. The common names are acetylcholine, pilocarpine, neostigmine, physostigmine. The tropical mediatics, cocaine, hydroxyamphetamine, clonidine. Then pupils and systemic medications. The most important pupillary sign caused by systemic drugs is narcotic-induced meiosis. This should be kept in mind, especially while examining the patient in emergency room. And the effect of morphine on the pupil correlates well with the plasma concentration of the drug. Whereas the dilated pupils can reliably be used to identify cocaine, amphetamine, and cannabis consumption. This is a very busy slide, but it is just to give an overview of the drugs that leads to meiosis. So systemic, the antihistaminics, antihypertensives, prazosin, and clonidine leads to meiosis. Among the antipsychotics, haloperidol, phenothiazines, and opioids leads to meiosis. And at times, sedatives, hypnotics, barbiturates are also known to cause meiosis. Poisoning. Typically, the pupils are spared in most of the metabolic and toxic conditions. In several sedative drug overdose or hypothermia, the pupils are mid-position and fixed, and the syndrome may mimic brain death. The lesions in the pontile tegmentum, which selectively disrupts the sympathetic outflow, can produce very small, less than 1 to 2 mm pupil, in which the light reflex is barely perceptible, and these are the pontine pupils. Opiate overdose can also produce this type of pupil, and the 3 Ps that we very well know for the causes of pinpoint pupil is organophosphorus poisoning, pontine hemorrhage, and the opium poisoning. So opioids, that is heroin, morphine, oxycodone, hydroxymorphine, they all leads to CNS depression and meiosis. And among the other poisonings, the cholinergics, that leads to coma and confusion, like organophosphates, nerve gases, nicotine, pilocarpine, physostigmine, they also leads to meiosis. Pupils do respond in coma, and they are also used as a sign for localization. So the lesions above the thalamus and below the pons usually have preserved pupillary reactions. Preceding ocular injury impairs the response and must be asked for before going for any prior examination. The pupillary fibers within the peripheral oculomotor nerve, as we have seen, are chiefly susceptible when uncal herniation is there, when the nerve gets compressed, and they usually leads to fixed and dilated pupil. The drugs such as atropine and dopamine that can be used in resuscitation for the cardiac arrest patients do have effects, dilatory effects on the pupil, and may be misleading and should always be thought for. Pupil is also used in the evaluation for differential diagnosis of coma. The pupillary abnormalities are an independent predictor of structural injuries. And the important thing that I found while studying for this seminar was the 4 score. This is the new coma scale, which is said to be better than the GCS scale. And instead of the verbal response used in the GCS scale, they use the brainstem reflex, the pupil reactivity, and the respiration. And they have given a lot of weightage to the pupillary signs as grading the coma. So it's not the end. I'll just summarize the causes of constricted pupil in another way. So the constricted pupil with a good light reflex, think of Horner syndrome. When there is constricted pupil with a poor light reflex, then think for chronic tonic pupil, Argyll-Robertson pupil, neuropathic pupil, and diabetes. Some says for chronic alcoholism, systemic medications, especially opioids, pharmacological meiosis, fibrous local adhesions caused by the previous intraocular surgeries or inflammations, and aberrant regeneration of the third cranial nerve, where in the chronic third cranial nerve palsies, the regenerating motor fibers, instead of going, they instead innervate the iris sphincter and leads to the constricted chronic tonic pupil. The future, we used to use pupil gauze to measure the pupil, but now it's being replaced by a pupilometer. So the future is of the pupilometer. There are a number of studies which are coming, and use of pupilometer in grading the brain injury, and even correlating the pupilometer findings with midline shift in an acute stroke patients. And the future is also about the pupils in sleep and cognition. I hope we all are awake. Thanks a lot.
Thank you, Neha. Thank you so much. It was a very lucid talk. Thank you so much. We'll have questions in the end.